Hello, good afternoon. This is Paul Landry from MI-UCP. I want to welcome you to Cerebral Palsy Talks. Today we're going to be talking again about physical therapy. No matter how old or how young we are, we need to keep moving. We need to keep exercising. Today we're going to talk to Dayna, who is a physical therapist from the U of Medicine. I do want to let you know next month, July 28th, we're going to have a speech by Thousand Celebration talk about troubling issues for people with cerebral palsy. Well, right now I'm going to focus on physical therapy. And then I'm going to just hand it off to you.
Thanks so much, Paul. As Paul said, my name is Dayna Ryan, and I'm a physical therapist at the University of Michigan Health System. I work in outpatient neurology, and I treat only patients with neurological disorders with kind of a subspecialty in pediatric acquired disabilities. Dr. Hapola was a speaker, and you got these sessions a couple months ago, or maybe just last month. And I work directly with her. We collaborate often. So I'm hoping you guys find some of this information helpful. I'm going to share my screen right now so you can see my presentation. Let me put it in presentation view. Hopefully you guys can see that okay. All right, so something I get often from people outside of or new to the University of Michigan Health System is they haven't had physical therapy since I was a kid. Nobody told me I would still keep needing physical therapy as an adult. They thought they were done. So I'm here to tell you all the reasons why that is not quite true. So here's the scoop. Basically, you could benefit from physical therapy for two key reasons as an adult. One is with the transition from childhood to adulthood, because it's a lot. It's a very significant, a time in everyone's life full of significant life changes, including like maybe you're going to college, maybe you're starting to work, maybe there's still puberty happening, you're trying to date. And where I really come in is people wanting to live independently and navigating obstacles that may be barriers to doing that initially. I also help a lot with planning for the future, more with a mindset of this is where I'm at now. Where could I expect to see myself in 10 years, 20 years, 30 years, 40 years, 50 years? Because primarily insurance changes at 26 years old. And so if things can get covered now before somebody is over 26 years old, I really try to help with that. If not, then maybe their insurance won't change. Then that's one less thing. But sometimes people with cerebral palsy stay on their parents' insurance till 26 if they don't enter the workforce sooner than that. So it's something I like to consider when planning ahead. Also, you could need to see me as an adult because simply speaking, it's proven by research that people with cerebral palsy age more quickly than their neuronormative cohort. So general practitioners, though, they don't receive specialized education regarding the unique medical challenges that people with cerebral palsy encounter. And so I really recommend that anybody with cerebral palsy finds a physiatrist or PM&R, physical medicine and rehabilitation physician near them. So here I'm going to detail now just some, this is by no means an exhaustive list, but some of the common complications that occur when you age with cerebral palsy. First of all, pain. the first example that comes to mind is that the gait changes, the way people walk differently when they have cerebral palsy causes pain after walking that way for a while. It isn't how the human body, human skeleton was structurally and biomechanically designed to operate. And so joints are wearing differently, and that just causes pain after a while. They might come to me more obviously for difficulty walking or impaired balance for a reason any other adult might come to see me. But maybe they need to see me in their 20s or 30s instead of their 60s or 70s. While it's primarily an OT reason, I still often see people for difficulty managing self-care, like wanting to live alone. And so I might work on the gross motor skills needed for self-care, whereas an occupational therapist, I might refer to them to do more fine motor stuff, but I still definitely work on self-care as well. Fatigue, constipation can happen even as a child, but it definitely seems to get worse when people are adults. Decreased bone density, muscle mass, early onset hypertension or diabetes. People with cerebral palsy are at greater risk for chronic kidney disease and the onset of that occurring sooner. Greater prevalence of anxiety and depression. And going back to the pain piece, greater incidence of osteoarthritis. We're still trying to figure out, we think it's because people with cerebral palsy have had spasticity acting on their body since before skeletal maturity. So not only do the joints wear differently, but they wear more quickly. And so trying to improve body mechanics with a physical therapist can help. But take home message, exercise can help with all of this. So seeing a physical therapist to learn how to best exercise for you works the best. There does look like there is a question in the Q&A. Let me just read it really quick. And if I'm going to get to it, if you don't mind, please keep putting your questions up here and I'll answer them all at the end. But let me just see if this is related. Access Medicare. So the question is how to access Medicare and Medicaid benefits when we're being told that they cap out at $2,300 for OT and PT. I'll answer that really quickly right now, but I can elaborate. If there's a second part to this question or my answer is incomplete, feel free to type it out and I will answer it at the very end as well. So Medicare has a cap, but you can go beyond that cap if you are continuing to make progress. Now that sometimes is hard to show when somebody has like a chronic condition like cerebral palsy, like you've had it your whole life and it's not going away. So admittedly that's hard, but that is a benefit for every year. And $2,300 can get you at least 15, if not more visits per year. It depends on if you're getting a 45-minute appointment or an hour-long appointment. So you can access these benefits at least for several visits. 15, if you're going twice a week, you get 15 visits, that's 8 weeks. So 2 months worth of physical therapy. So it's better than nothing. But you're right, there are plenty of insurance limitations. I 100% agree with you. Insurance is the bane of my existence, I feel like. All right, moving on to the next slide. Maybe. Will work now. There we go. Consequences of increased spasticity. So spasticity, if you're not aware, are those spasms that you get in your muscles that you can't control. And some of them are very strong and some of them are not. The only reason why I'm spelling this out is because I've been surprised how many patients I've met in their 50s, 60s that have cerebral palsy that did not know that those spasms were called something. So anyway, spasticity can be pretty painful. So if they're strong enough, they can be quite painful, or depending on the muscle they occur in, it can be painful. The problem is that when you have a lot of pain, it further increases the spasticity. So say you have a spastic muscle and that pulls on a joint that's already arthritic, that can cause pain, but then the pain from that arthritic joint makes the spasticity get worse. So it really is this vicious cycle. So if we can do something to improve body mechanics or lower your spasticity, we try to do that. Contractures can develop from increased spasticity. This primarily occurs in wheelchair-bound individuals or people who use a wheelchair for any percentage of their day. Doesn't have to be primarily wheelchair-bound. Dealing with too much spasticity is incredibly taxing energy-wise and can make movement patterns that may already be abnormal worse. It causes abnormal posture. It can cause difficulty breathing. So another unknown thing about spasticity is that it only occurs in arms and legs, but really it occurs in the entire body, including the trunk, which makes breathing difficult, which you need to do just to live, but also to exercise. So it's a deterrent from people really pushing themselves with exercise if it's too much labor to breathe. It obviously makes walking or transfers more difficult. If you're spending too much time in sitting, it can cause shear or pressure, resulting in skin breakdown or sores, which is a site for infection, trying to avoid that. And that doesn't always have to happen with people who sit in a wheelchair most of the day. It can happen with ambulatory individuals, just depending on how the pressure is. So one we see a lot is in the hand. If it's hard to open up your hand, then if your nails grow too long or something, that pressure into the skin can cause skin breakdown. Another one I see is the insides of the knees. If you have hip adductor spasticity, pulling your knees together, that pressure on the bony knees can cause skin breakdown. And on that same token, it can interfere with your ability to perform hygiene. If you don't have good hand dexterity to perform all of your many hygiene needs, that's another risk for infection. Difficulty sleeping. If you can imagine a spasm many of you probably can't imagine spasms happening throughout the night that wake you up or make it too uncomfortable to find a position to fall asleep in. And then the worse your spasticity is as well, the more work it is for both you to move and anybody that may be assisting you move. This is a slide I like to put in here about when I talk about spasticity, because doctors use it, and often it is medical terminology that patients don't understand. So I like to throw this out there in case anybody has seen it in their notes. It's called the GMFCS scale. Spelled out as the gross motor function classification system. And it is a way for doctors to classify people with cerebral palsy based on how severe their spasticity is. And it's a sign of your overall function. So if you are a level 1, you are less impaired by spasticity from cerebral palsy. And if you are a level 5, you are more impaired, needing a wheelchair for mobility. So now let's get back to how do we manage this spasticity? We see how it's a problem. So there's lots of ways, pharmaceutically as well as other options. And the nice thing about my job, and I get to work very closely with physiatrists like Dr. Hapola, is we work together to decide which might be best for patients. Baclofen is probably the first oral medication that maybe many of you are very familiar with. You can take it orally, or it can be administered in an intrathecal pump. And that is in place for 6 to 7 years before the pump is taken out and replaced, like the hardware is just replaced. Many people like baclofen, but struggle if they start needing too much oral baclofen, because the side effects can be significant depending on the individual. It can cause like brain fog and fatigue most commonly. And so maybe somebody drives, but if they take baclofen orally, it makes them unsafe to drive. So they start considering an option like a pump, because the pump would allow a much, much smaller dose to be administered, because there's a catheter from the pump that it puts it right into the spinal cord to suppress spasticity that way. We do trials at University of Michigan to determine if a pump is an option for a person before it's surgically implanted. And we do that once their oral dose of baclofen gets so high that they are kind of near the ceiling and having secondary side effects that are impacting their life. If your spasticity is more localized to just a couple of muscles, Botox injections are a great option. And this is where I really work closely with physicians to determine precisely what muscles might be most beneficial and what doses would be good for each muscle. Also, tizanidine, dantrolene, Klonopin, and Valium are other options that suppress spasticity. Though I put those in order of which they're prescribed for the use of spasticity. Tizanidine isn't as effective as baclofen, but the more effective than the other three without as many cognitive side effects, but it doesn't work as well. So and then like maybe one makes people sick, one doesn't. So we have options, but pharmaceutically, those are it. Other options, and this is where I come in, stretching. There is not a ton of research to support that stretching suppresses spasticity long-term for more than the day you stretch, unfortunately. So it's just like brushing your teeth ends up having to be a lifelong daily thing that you do to manage your tone. Tone and spasticity kind of tend to be used interchangeably in my world. But it's still an option nonetheless and can help with pain or spasms in the moment. Exercise, there are mixed reviews on this as well, but exercising the spastic muscle is what I mean by that. Exercise for the antagonist, the opposite muscle of your spasticity, is highly recommended because it helps make you stronger than your tone, if that's possible. So exercise is great. Just you need to be specific in your prescription. Weight bearing, especially if somebody does not stand, weight bearing is awesome for lower extremity spasticity management. That's usually done in a standing frame for your legs. In your arms, it's ability to achieve 4-point or quadruped or crawl position. Not sure what everyone is familiar with. Hopefully you can envision the position, but being able to put weight through the limbs helps suppress spasticity. Functional electrical stimulation, and then serial casting. So serial casting provides a low load prolonged stretch and is done by a physical therapist or an occupational therapist, depending on the clinic. So why might an adult with cerebral palsy go to physical therapy? 90% of them come because something started hurting. And then I meet them and we break down why, the cause of the pain, because seeing me might not take your pain away your first or second session. A lot of people's experience with physical therapy with cerebral palsy is an orthopedic clinic, and they don't understand the cerebral palsy component to it. So they put hot packs, cold packs, TENS units, ultrasound to try to short-term alleviate the pain. And I'm not saying that that's a bad thing, but we're only treating the symptom in that case, not the cause. So I end up seeing them because then the pain got bad enough that it heightened their spasticity and started making moving harder. So really what I'm trying to investigate is what's causing the pain. Joint degeneration. As I said before, this population is aging faster than their neuronormative counterparts, especially in terms of arthritis. So I'm working on improving biomechanical movement patterns to slow the process of arthritis, because we all will get it. It's just, will it give us pain? Figure out how to exercise and maintain your fitness. Exercise equipment is not made for even half of the population. I'm only 5'2", and I struggle physically getting on and off some equipment, adjusting it to fit me. So people that move even more differently struggle even more. So it is my job to get creative and figure out a way that can allow somebody, no matter how they move, to exercise in some way and increase their heart rate, because doing that improves the incidence of all of those comorbidities that I listed earlier. Diabetes, heart disease, kidney disease. Exercise that helps with it all, even mental health issues. And because the incidence is higher for these comorbidities in this patient population, we really try to find a way to help everybody exercise in some way. caregiver training. So this is more for people who rely on others to do activities of daily living. And 90% of the time it's their parents. And their caregivers are aging as they are also aging, and we don't tend to get smaller as we get older. So how can I teach transfer techniques to caregivers in a way that will allow that caregiver to continue to assist that person for as long as humanly possible? That might mean lifting technique, improving lifting technique, or is there equipment that we can get sooner, or is it something that financially we'll need to plan for, or we can put that plan together. And then transitioning to adulthood, I actually am working with somebody right now we're trying to figure out how they can use the kitchen, their kitchen that is not handicap accessible at all, but how we can structure and rearrange where pots and pans and things are at, so they can live independently without needing help from caregiver or other family members, parents, hiring a caregiver, etc. Musculoskeletal health, they might come see me, like I said before, for joint preservation, but also for bone density preservation. If somebody doesn't stand or walk with any regularity, they're more likely to struggle with osteoporosis and osteopenia. And some, like if you're Caucasian and female, you're more likely to get it as well, just naturally. So any ways that we can preserve bone density, the better, because in the event of a fall, if you already have thin bones, it could more likely lead to a fracture, which is devastating when you have spasticity. So trying to avoid that with at all possible, that's what we do. Spinal deformities, I have yet to meet somebody with cerebral palsy that doesn't have at least mild scoliosis, just because, as I said earlier, that spasticity is acting on your spine since before skeletal maturity. So, sorry, I got a page. That spasticity is acting on your spine before skeletal maturity, and that very easily causes those soft vertebrae when you're before puberty to wedge. So people have back pain and they wonder why. And if it is from a skeletal deformity they've had their whole life, like that's good for me to know, so I can teach stretching and strengthening routine to minimize that pain as much as possible. Preventing functional decline. As movement patterns change, as you get older, they tend to change to accommodate this increase in pain and spasticity. We're all at the end of the day just trying to survive. And if we can move in a little bit different way to avoid pain, we're going to do it. But is that worse for us biomechanically in the long term? I'm trying to help change those movement patterns in hopes to reduce the pain, but also not further degrade the joints. And then energy conservation strategies. We're really trying to keep people aging in place for longer. So the planning needs to start sooner, because financing is an issue. If a physical therapist told you, well, I need you to move. You live in an inaccessible house for this, and this reason, if that's not an easy thing to fix. So talking to them sooner rather than later about that. And then unfortunately, the topic of wheelchairs does come up quite often, and it's an uncomfortable topic, but I try to have a conversation about risk reward. Like, if we can make your home more accessible, or maybe your home already is accessible from a wheelchair level, could we start using a wheelchair sooner for some things that wouldn't degrade your body so quickly and as often, to help with things like pain and fatigue, because you're just tired from working so much harder to do everything in standing. So hard conversations, but they're good to start having with somebody who cares to make it better. There is a lot of research being done on cerebral palsy and aging, so I wanted to include that. A lot of it's being done at the University of Michigan right here, and I'm on the team that helps with that. So fortunately or unfortunately, the incidence of all of these comorbidities that you see listed here are more common in adults with cerebral palsy versus their neuronormative age-matched cohort. So, but as you can see, most of these comorbidities can be improved or prevented if with regular exercise. Like, for example, the way to prevent myocardial infarction or coronary artery disease or stroke or diabetes is to exercise. And unfortunately, we don't target exercise to people that move differently. So that's our mission as physical therapists, is to help everyone be able to exercise to prevent all of these possible secondary problems. So now, what might you see in a PT clinic for somebody with cerebral palsy that is different than maybe you might have had in your previous experiences, or in an the orthopedic clinics are way more common than neuro rehab clinics. So I'm hoping to show you maybe some things that you haven't seen and you might inquire about for clinics near your house, if they might have some of this technology. So the first one is functional electrical stimulation. It is not what's pictured here. Basically, a physical therapist would use electrical current, putting electrodes stuck onto your skin to contract a muscle of in your body in a volitional way, using settings unlike a TENS unit that's just meant to take pain away. And by the way, it makes pain go away by just giving your brain something else to think about, to something else to sense other than the pain. It's not actually fixing the cause of the pain. It's like tricking your brain. But now this kind of electrical stimulation actually contracts the muscle the way it's intended to, with a given movement, and can help suppress spasticity at the same time. So I use it a lot as a tool to teach adults with cerebral palsy how to use their muscles correctly and volitionally outside of their spasticity patterns. So why I love working with this particular patient population, as opposed to somebody who maybe had a stroke and has spasticity, or has a spinal cord and has spasticity. Adults with CP have never moved typically, but somebody with a stroke or a spinal cord injury, they maybe walked however many years of their life, normal, typically, biomechanically typical. But this is what I get to teach somebody who's always had spasticity acting on their body their whole life. It's really, really eye-opening once you really have discussions with, oh, you didn't know this was supposed to move then, and then I teach that muscle how to contract, so the brain can learn how to make the muscle contract on its own. And then what you're seeing in the picture here is called a Locomat. It's an overground treadmill with robotic legs. And I use this machine for two reasons with adults with CP. First, to ballistically stretch, which means just stretch with movement. That's a fancy word for stretch with movement. Ballistically stretch a patient in a functional pattern. So how their body is meant to do normal ambulation. And then that in turn can help teach proper motor coordination and joint position during gait. But if somebody's never moved in that way, you can't just expect them to watch and know. It's just not possible. Assistive devices. So a lot of times as a kid, they still use reverse walkers or posterior walkers to teach kids how to walk, facilitating their tone. But after 20 plus years of that, it wears the joints. And so we start looking in the adult world, how can changing walkers, assisted devices in general, crutches, whatever, to improve your joint positions and be better for your body long term. So between walkers and crutches, like that's really heavy on the arms. So if upper extremity pain are becoming an issue, then we do start considering wheelchair options, not just for community ambulation, but also just general energy conservation and joint preservation. And then orthotic considerations. this is always the like sensitive subject because when I see people for the first time when they haven't had physical therapy in a while, everyone tells me, oh yeah, I had those braces on my ankles as a kid, but I stopped wearing them in middle school and I got picked on, and now I don't need them anymore. I'm like, well, but like you're not walking in maybe the best way possible and you're having a lot of pain. Is there an orthotic we can find for you now that maybe fits you better and would support you in a way that you wouldn't give you so much pain and could allow you to walk maybe faster with less work. So we do a lot of orthotic trials here just to see if they work before bother ordering you any. We have a lot of options. And actually, as a plug, orthotics have changed a lot since maybe, I don't know the age of the audience here, but maybe since you last saw them. So for example, the girl in this picture here is wearing two carbon fiber ankle foot orthoses that are very lightweight and very popular and among adults with cerebral palsy because it helps them stand with their knees completely straight as opposed to in a crouched position. So yeah, they've come a long way. And if you have a physical therapist who's willing to trial options with you before ordering, that's a great benefit. Other interventions include stretching. You have to be creative sometimes to figure out the best way, because the best way each person likes to stretch is different per person. So you really have to just try a bunch of options. It's not just looking at a picture or watching a YouTube video. You got to practice and find out. Learning how to strengthen weak muscles the best way while avoiding compensation patterns. Because biomechanically, we are trying to get you to move in the best way for you. Balance training, core strengthening, and the core strengthening helps a lot with the postural reeducation, prevention of worsening scoliosis. We might cover caregiver training, and then again, energy conservation strategies. Home exercise program ideas that if you haven't been given in the past, they're always part of home programs I provide for people. Obviously stretching. The most common muscles that are spastic in adults with cerebral palsy are your hamstrings, quads, hip flexors, and plantar flexors. I spend a lot of time on education, so I like for my patients to be able to say specifically what their spastic muscles are, not just relying on the doctor to know best. So yeah, teach stretching of those muscles. Posture corrections are great to do at home because a lot of times people have impaired proprioception when they have cerebral palsy. And that just means, it's a fancy word meaning knowing where your body is in space. So I have patients who don't realize they're standing completely on their one leg and not at all on the other. And they do everything on the one leg. And so after several decades of, say, their left leg doing all of their sit to stands, anytime they're standing still, maybe cooking dinner or whatever, the left leg is upset and has pain and says, okay, enough is enough. Maybe they don't realize they've been bending their trunk to the right for years and years, and now they have back pain and don't know why. Well, I commonly teach exercises to correct posture, standing in front of a mirror or using various props to help cue people to use their muscles appropriately and get their vestibular system to relearn what upright is so they can feel it without the use of the mirror. And then, of course, strengthening. Glutes are always, that's your butt cheek muscles, they are always weak. Just in adults, if you're old enough anyway, and then when you add cerebral palsy to the mix, it's just how those posterior walkers taught people how to walk when they were a kid, and then they develop a pattern that makes them able to walk using their glutes as minimally as possible. So I end up having to spend a lot of time figuring out the best way for somebody to strengthen their glutes. Quads, because if the stronger quads you have, the less crouched you'll be, and then core strengthening. So I asked my patients for feedback on this as well when I was putting this presentation together. So I wanted to throw this list out here. So it's like, what do you think is helpful when finding a physical therapy or physical therapist near you? Because I can't assume that everyone lives in near a neuro rehab clinic. So a lot of clinics, a PT will evaluate you and then you will see a tech the rest of the time. This is not ideal when you have cerebral palsy because compensation patterns happen and you don't even realize it. And if your PT is across the room and an unskilled tech that's not used to looking for these things is working with you, then they won't be able to correct you. So you could be doing something wrong and possibly giving yourself more pain than if you're one-on-one with a physical therapist, not a tech. Ideally, it would be a physical therapist that probably specializes in neurological conditions because of that spasticity component is so important. But if they have comfort with orthopedic issues that arise, that is really helpful as well. A PT that's comfortable with different bracing options, not just for the legs, for the arms too, would be, or the spine would be ideal. Comfortable with assistive device options and keeps up to date with, I mean, there's always new things coming out, can keep up to date in the setting that they work in on new assistive device options. That are great with, or that are good with understanding goal setting and prioritization. One of my patients said that it was helpful to have it broken down. First, we need to improve this. Then we can work on and getting this, this aspect of living alone better. Then I can build on that and do this. And it was helpful for him to see the set priorities there for his goals. And then I will say is really helpful to be creative because I have had to MacGyver so many options to help patients do what I need them to do without compensation. And it's humorous, but requires a lot of creativity. So that is my presentation. I hope you all enjoyed it. These are two of my patients that I think many of you might know. They used to be a part of the UCP regularly. So yeah. At this time, I'll field some questions. Okay, so I don't know who this is, Kay Pleasant, but she said, what's your opinion of using a rhythm vibration plate in a workout regimen? So some people love vibration and it seems to be not standard across adults with cerebral palsy. Some tell me it relaxes them so much, the rhythm just relaxes their spasticity a ton. And others have told me it's quite painful. So I think my answer to that would be try it. And if you like it, use it. I use it with the people who like it, but I tend to try it with just about everybody just to find out, because finding out it doesn't work is helpful too. Any other questions? And I can stop sharing my screen too, so I can see everybody.
Dayna, what is your opinion on massages and seeing a chiropractor?
Good question. So massages are great. I love massages too. They can really help with pain and muscle relaxation for a little while. It unfortunately doesn't last, but I mean, I like it too. So I'm very pro massage. Chiropractors, I definitely think they have a purpose. The hard part about chiropractors, and specifically for adults with cerebral palsy, is the spasticity component. So chiropractors do high intensity joint mobilizations and you get that gratifying pop and you do feel good right away. The best analogy I can use is if I was stuck sitting in one position and could not physically move from that position for days and days and days, simply moving would feel good. So when you're getting those pops from the chiropractor, the movement itself is going to feel good. What I don't like about chiropractors is some of them overpromise. They want you to keep coming for the rest of your life. And usually when you do those high velocity, high intensity joint mobilizations like that, you're only moving the joints that were already hypermobile, not hypomobile, didn't move enough. You're not, it's hard to get specific hypomobile joints to move in general. And then you add a spastic muscle to it that can't relax, and you're really hard to get that hypomobile joint to work. So the problem is with the chiropractor is they want you to come forever and ever and ever. But when they're doing those repeated high velocity, high intensity joint mobilizations, they can make joints that are already hypermobile even more mobile, which causes pain. So I've been to a chiropractor myself. I had a random pinched nerve in my neck years and years ago, and they fixed it in about 4 visits. But the problem is he wanted me to keep coming after it was fixed. So, and he made this particular chiropractor, not all chiropractors, but this particular chiropractor said he could cure my allergies. I'm like, whoa, whoa, whoa. So I think that chiropractors are great in their scope, as long as they don't over deliver or over promise. And if there's not some expectation that you go forever and ever and ever, because the joints that they're mobilizing are just going to be your hypermobile joints, not the ones that don't move enough that really need it. Any other questions?
Anyone else? There's 2.
Okay, got it. Will this webinar be available on the UCP website?
Yes.
Cool. And then
And also on YouTube.
And then the other one is again from Cape Pleasant. I'm an adult with spastic diplegia who found cerebralpalsypositive.org. You work, oh, good. You work with Dr. Hurwitz. If you'd like to, I am familiar, I work with Dr. Hurwitz as well, and the CRPN network. But yeah, I would love to meet anybody. It sounds like we know a lot of the same people.
Yeah.
So Paul, maybe I should ask a quick question. If when you guys post this, do you put my email, my contact info when you post it?
I could usually I put all contact information.
Okay, how about I then put my name and email address in the chat?
Okay.
And then anybody who wants to use it on this chat at least can have it, and then or that's on this right now can have it, and maybe you could get a hold of me, Paul, if someone else reaches out to you.
I will for sure.
All right, because they'll be hearing this part live, so
Yep.
or they'll be hearing this part recorded. So
yeah.
All right.
Thank you. We had about 8 to 10 people on the webinar. Besides the presenters, so thank you very much.
I am just real quick before we end this, I want to send this through the question and answer. John, will you let me know if you can see my email address in that one now? If I did it that way instead of the chat. I didn't realize the chat was disabled.
I see it in the chat.
Perfect. Awesome. It's in the question and answer part. Perfect.
Yep.
Okay.
Yeah.
Well, it's been great.
Thank you very much. I really appreciate your time on a Friday afternoon.
No problem. I'm happy to do it.
Okay. Thank you.
Bye-bye.
Bye.